So now we sort of have an understanding of why we are going to be doing this and who is the right patient. And so what I want to spend the next few minutes talking about is how do we now go about it? You all sort of, if you have not actually already started using this, you're anxious to sort of write a prescription for it and get your first asthmatic out the door with this. The thing is, unlike anything we in this field in pulmonary have previously been used to prescribing, such as inhalers and other forms of medications, these involve a lot of thought prior to actually initiating this. And that is what we are going to do. Incorporating giving biologics to your patients in your practice, no matter what type of practice setting you're in, is going to involve a lot of process mapping and really figuring out if this is what you want to do. The very first thing you're going to do is, do I want to start actually doing this? Perhaps the payer mix or the patient mix in your practice may make it more favorable for you to refer out just that percentage of severe asthmatics in your practice to maybe somebody in your region who does this. Having said that, I would certainly encourage you to start thinking about incorporating this for multiple reasons. One, this is only going to get more and more prevalent, and sooner or later, you're going to have to jump on the bandwagon. There are significant benefits to the patient. This provides an opportunity for patient education beyond the 20-minute or 15-minute follow-up visit that an E&M visit entails. Here, you sort of have the patient captive with you for a longer time, more frequent contacts, monthly contacts, provides time for your team, if not you yourself, at least an important member of your care team, to spend more time to the patient, educate them about smoking cessation, about inhaler use, psychosocial support, and really build that connection and rapport with the patient. Convenience for the patient is important. If you're going to be referring this patient out to a center 45 minutes away, chances are they are probably not going to be very compliant. There may be scheduling conflicts that may also play a role. And certainly if they are referring them to a hospital, we'll see in a couple of slides, there's major implications in terms of billing and finances for that. So depending on the setting, there is a huge difference in the financial aspects of biologics. If you just take Remicade, for example, so to walk you through the slide, this is Medicare billing and this is private payers. So 100% is the line that is pretty much an equivalency line for physician-based administration of biologics and hospital-based. So if it's 100%, it means that there was no difference between the physician administering in his office and the hospital administering it. But now you come to the private payer side, and here you have a 270% increase in costs. And the reason that this is, and I could spend an entire next hour talking about this, is that the payers will actually allow these hospitals to procure these drugs at ridiculous cost, some of them as low as a penny, believe it or not. So that the same thing that the office would spend in a buy and bill model, thousands of dollars to procure, the hospital will procure it for a penny and rake in and actually provide it at a much higher cost. And there is a lot of nuances and intricacies to this, which we'll not go into, but the bottom line you need to know is that 100% of the time, if you're going to export this entire process to your neighboring hospital, it is going to cost somebody a lot of money. It may not be the patient himself, but it is certainly not good overall for healthcare. I would encourage all of you who are going to do this to actually have a policy and procedure manual clearly labeling out exactly how you're going to be doing this, whether it is mepolizumab, which is sub-Q, versus restylizumab, which is IV, or any of the others that are now coming down the pipeline. It assures best practices for each drug. It really does protect your professional liability to have this all written down. It supports the nursing staff. Actually have the nursing staff be involved in drafting some of the process mapping in that policy document so that they find it easy to follow. A policy that's not easy to follow will, of course, not be followed. Staff requirements is something you're going to have to think about. Are you going to need, RNs, LPNs, particularly if your practice doesn't currently have them? Would certainly encourage you to look at physician extenders and nurses with experience in an infusion team. This is going to be a team-based care like your practice hasn't seen before if you're going to start doing this, just by the nature of it, which is actually an advantage because it actually, a team-based care, which is patient-centered, is sort of where healthcare is moving towards, and adopting this may actually allow you to do multiple other functionalities with that team of yours, whether it is counseling, whether it is smoking cessation counseling, is it home-based rehab using telemedicine, creating a patient-centered medical home, like we saw in the other session. So there's a lot that you can do with your team. Remember that physician presence will need to be present for Medicare reimbursement. So if you're going to be getting reimbursed for giving mepolizumab in your office, you actually need to be physically present. There's obviously patient safety implications that may require your present as well. So think of all the costs that you're going to be harboring, particularly if you're an independent practice, all the overhead that this is suddenly going to bring in. Patient scheduling, make sure you have at least 2 to 3 months allowed in advance. You need to have reminder systems so that patients actually keep up to speed with this. Lapses in compliance are going to start becoming frequent. Once you start having 50, 60, 100 patients on this coming in every month, you're going to start having some scheduling nightmares. Patient suddenly doesn't show up, or he calls in the morning saying he's not going to show up. How are these lapses going to be communicated to you, the provider? How are these patients going to be rescheduled? And so those are all considerations that you need to do. How are you going to coordinate the time? Are you going to set specific days in your office where these infusions will be given, or are you going to pretty much give it on all days randomly? Are you going to, I certainly would advise you to set aside specific time for your more high-risk, complicated patients. Make sure patients know what to expect. Are they going to be seeing you, the provider, or is it just a quick coming in, getting the injection and going out? Do you have Wi-Fi? Especially if you're going to be doing reslizumab and starting a IV infusion. So make sure patients have a good idea about what kind of a patient experience they are going to be expecting. Patient safety, extraordinarily important. Do not venture into this without spending a lot of time being mindful about what is the process mapping in your office for dealing with emergencies. Do you call 911? If you're in a medical office building next to a hospital, interface with that urgent care center or the ER and define how is any type of emergency going to be handled. Are you going to be involving the hospital next door, or are you actually going to be activating EMS? Is a stretcher available? Is your crash card up to date? Make sure you have monthly periodic checks of the crash card, the defibrillator is working, the batteries are up to date, so on and so forth. I mean, this is exceedingly important. One disaster here can completely derail your program. So do not venture into this without that being mindful of the safety aspect of it. Next, we will go into the actual nitty-gritty in terms of the business of the biologics. And again, we could spend a whole lot of time here, but I'll try to kind of give you a very kind of a synopsis of this and walk you through what are some strategies in terms of buy and bill, what are some acquisition contracts, insurance contracts, and some of the codes that you're going to use. So this is sort of what your startup costs are roughly going to be looking at. This is basically borrowed from the rheumatology literature. This is per bed. It's not really that high considering other types of infrastructure. So the cost of actually procuring an infusion chair and making sure you have catheters and all of that stuff is not, the fixed costs here are not much. What is really going to cost you is the personnel. You're going to be having to hire an infusion nurse, potentially physician extenders. That is really where the bulk of your cost is going to come through. There's two main pathways. So you've sort of decided you're going to do this, you've hired the right people, you've put the right team together, you have your patient safety all mapped out. Now, how are you going to actually get the mepolizumab to give to the patient? So there's two main strategies. One is assignment of benefits, which is also called white bagging, and the other is buy and bill. So buy and bill is where you establish an account with a wholesaler, you buy it, and then you bill the patient's insurance plan. And this comes under their Medicare Part B, which is kind of your fee-for-service. So it's advantageous to the patient. It doesn't come under their prescription drug benefits, which is your Part D. Assignment of benefits is basically comes under your Part D, the prescription drug plan. You use a special pharmacy like Accredo or any of the others, and they are going to ship specific doses of the medication to you. The specialty pharmacy will take care of handling, verifying the patient's insurance and getting all that authorized, and then the specialty pharmacy will bill the patient for any co-payments and so on and so forth. So what's happening out there in the non-pulmonary world in rheumatology and specifically in oncology, most providers, particularly if they're community-based, are doing buy and bill. Very, very few of them are doing the white bagging, and then brown bagging is actually extremely rare. That is sort of asking the patient to take all the headaches of getting the mepolizumab, and then he simply brings it to your office and says, hey, give me this medicine, give this medicine to me. So probably not many of you are going to be doing that. So buy and bill, this is sort of the process map for that. This is your patient, this is you, the provider, mostly in your office, or it could be a hospital, outpatient, or clinic. You're going to administer that drug and get a co-payment from the patient. You're going to negotiate out a contract pricing discount with the manufacturer. You're going to have an agreement with the vendor, which is actually the drug wholesaler. So the manufacturer will ship the product to the wholesaler, wholesaler ships it to you, and then the manufacturer actually will have a chargeback for contract pricing. This guy will have a service agreement with the manufacturer. Very interestingly, the manufacturer will actually get a rebate payment over to the payer. Notice there is no rebate payment to the patient ever, right? That wouldn't ever be good. But so essentially, the payer then gets the rebate for this drug directly back from the manufacturer, depending on the contracts that they have. So this is sort of overall how this thing is going to work. You pretty much interface with the drug wholesaler, get the drug, give it to the patient, collect the coinsurance or co-payments from the patient. So your role is order the drug from the distributor, you prescribe it, obviously, administer it, provide medical justification, bill the payer then for drugs and administrative services, counsel the patient about what their coinsurance is, and collect that coinsurance. The distributor has to negotiate the cost of the drug with the physician office, fulfill the drug order, ship it, bill the physician office for the drug and establish payment terms. And then the payer has to basically have coverage rules, determine benefit structure, negotiate payment for the drug, and then process claim and reimburse the provider who has billed that. If there's only one sentence from my talk that you're going to remember, it's going to be this. Pre-authorization is a must. Can you all repeat after me? Okay. Pre-authorization is a must. Do not ever do this unless you have pre-authorization. It doesn't matter if the patient actually has a letter from the insurance company saying their drug has been approved. That is not your pre-authorization. Just one administration, one single administration of mepolizumab or reslizumab in your office can set you back by $4,000. And if it's been 3 months and before you realized out of the 50 patients you have this on, that there was one patient where this went through and you didn't, without pre-authorization, you're going to be in the dock for $15,000, $20,000 easily. And multiply that by 10 patients and you can kind of do the math. So denial or unreimbursed cases could really mean a big loss for you. So setting aside time each week for denials, appeals, billing, becomes exceedingly important. You will need to have a purchasing account that is set up. Obviously, I don't need to go tell this audience what a painful process, prior authorizations is. It is estimated it's actually costing the healthcare economy about $31 billion each year, about each practice on an average spending about $70,000 a year on this. So having a policy for centralized handling using technology, compiling a list of necessary documentation, it is going to take time for all those reimbursements to start coming in. So make sure your practice is going to be able to absorb all these administrative expenses prior to that. This is how Medicare reimburses you. Basically, it's an average NASP, which is your average sales price plus 6%, or the WAC, which is your wholesale acquisition costs plus 6%. Private payers are going to pay a lot more than that. Most of them do. Some of them may follow Medicare mandates and set their own pricing. So really, you have to know what these contracts are with each of your private payers as you build your financial projections for this. So tracking all of this is going to be important to know how you are doing with your overhead and how financially viable is this process proving to be for your practice. You really need to know your itemized per service cost depending on your payer mix and your staffing setup at the office. So moving away from buy and bill to sort of assignment of benefits, which is white bagging. Basically, this is administered by a PBM, a pharmacy benefit manager. Under this arrangement, a specialty pharmacy will pretty much take on this role. They will ship the dose to you for that one particular individual patient after dealing with the insurance company and after dealing with the patient, collecting the co-payment from the patient and collecting the approval from the insurance company, and then they sort of bill the insurance company directly. So this is sort of no longer the practice at the center of this universe. It is a specialty pharmacy here. They deal upstream with the wholesalers and manufacturers. They deal downstream with the practice, and they deal directly with the payer. The only thing that the practice will deal with is basically directly with the payer in terms of getting reimbursed for the professional or the administrative component. They don't deal at all with the patient in terms of financials. The co-payments for this drug are directly dealt with the specialty pharmacy. So again, a very different paradigm than what you're used to. And I know some of you are thinking, well, this sounds much easier, right? Because essentially, I don't need to take any of these headaches. All these headaches are now exported to the specialty pharmacy. All I do is if the patient shows up, I give him the drug, and then I just forget about it. Well, it's not so simple. And in reality, the administrative burden is going to be many-fold higher if you do the white bagging. And the reason is that you end up being the big coordinator, kind of the traffic police, between the pharmacy and the patient. Patient will fail to pay his copay, pharmacy will not ship it. Patient scheduled on the 30th of June shows up in your office. He has forgotten the copay. The drug medication is not there. Now you have a 30-minute slot that is going empty in your clinic. And if you start multiplying that by 20, 30 patients, it is very quickly going to be a logistical nightmare. Your staff is going to be spending enormous period of time trying to make sure the patient pays his copay, trying to make sure the pharmacies actually shipped it. It'll become logistically impossible. I can attest to this from my own experience. It becomes a logistical nightmare trying to keep your schedule sane and also coordinated with what the specialty pharmacy has shipped and not shipped, especially when your volumes start to really build up. So billing and coding, these are the CPT codes for OMAM, EPO, and Reslizumab. Those are the J codes. Basically, the 96372 is your therapeutic injection, subcutaneous or intramuscular, because obviously both Xolair and Nucala, they are both with the sub-Q, and then your intravenous infusions with the Reslizumab is going to be the intravenous, the 96365. And that would be the J code you're going to be using for all three. They all have established J codes now. When you submit a drug claim, if it's your office-based, make sure you put in the place of service code as 11. That sort of identifies that. Make sure these documentations are sent in within 24 to 48 hours. A few billing tips: avoid super bills. Smaller, more frequent billing cycles will get paid a lot easier. Adequate staffing for billing. Do not really scrimp on billing staff, because if you have too little of them, you're not going to be processing these claims, and that's going to mean less cash flow to cover all your other expenses. Standard drug prices and reimbursements are going to vary greatly, so be aware of that. Very importantly, the payers, believe it or not, are always going to underpay you. And so actually see what it is that you got in payment, and then have some software, preferably if you're using an electronic billing, or your actual office staff, look into how much you got underpaid and have a process in place to fight those underpayments, and so ultimately receive the correct amounts. Exceedingly common. If you don't think this happens, you'll be in for a rude awakening. This is the reimbursement claim form. There is support on the website for both mepolizumab, restlimumab, as well as for omalizumab. Um, I'll kind of skip this in the interest of time. Patient support, just be aware again on the websites that there is patient support programs if the patients end up with financial issues that they cannot pay. As long as they have insurance, this has never ever been an issue. There is always some form of patient assistance. I shouldn't say never, but very seldom been an issue in practice. There's Xolair as a copay card program, and as does mepolizumab as well. Restlimumab has these cost support program cards, so there is a lot of resources. This is sort of one website that actually helps rheumatologists and now I guess pulmonologists in terms of setting up office-based infusions. It's infusionnet.com. I have nothing personally to do with it, but it's just a resource I found on the internet that actually lays everything out pretty clearly. So with that, I'll stop, and hopefully we have time for a few questions.